We will go ahead and call to order our Treatment and Recovery Subcommittee meeting for Nevada's SURG, the Substance Use Response Working Group. Great to see everyone. Our first item of business and agenda number one is the roll call. So I will turn it back to Kelly to make sure we have quorum today.
Right. Thank you, Mr. Chair. Kelly Marshall for the record. Chelsea Cheatham.
Here.
Stephanie Cook.
Here.
Dr. Dixon.
Here.
Assemblymember Edgeworth. Assemblymember Goulding. Giuseppe Mandel.
Here.
Steve Shell.
Here.
Mr. Chair, we have a quorum.
Great. Thank you, Kelly. And just to remind everyone, we do have a special session going on in Carson City today. And so we're not quite sure if Assemblymember Edgeworth and Assemblymember Golding may be tied up in that today. So if they are, we wish them well. But if not, hopefully they'll be able to join us momentarily. The next item on our agenda is public comment. I'll just read a brief statement and then turn it over to Kelly for some of the details, other details. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241021. So Kelly, if you want to take it from here, share any other details.
Happy to. So if you're dialing in from a telephone, please dial 253-205-0468. And when prompted, enter the meeting ID 894893752998. Press *6 and we will unmute you if you would like to make public comment. Also, if you are interested in making public comment and you can raise your hand, we will call on you that way as well. So, Mr. Chair, I do not see any raised hands and no one has pressed *6 and prompted me to unmute them.
Okay, thank you, Kelly. It looks like that will conclude public comment. We'll have another period before our agenda ends today. So moving on to item number 3, this is a review and approval of our minutes from our meeting held on August 19th, 2025. Hopefully our committee members have had a chance to review the minutes. And if so, we can entertain a motion to approve.
Dr. Dixon, I'll move to approve.
Thank you, Dr. Dixon. Do we have a second?
Chelsea Cheatham, I'll second.
Thank you, Chelsea. Do we have any discussion regarding the approval of the minutes? All those in favor, please say aye.
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 Any opposed? Motion carries unanimously. Thank you. Our next item, which we wanted to spend a little bit of time today on, is due to having several new members on our subcommittee, is an introduction of our new subcommittee members. So I'm very excited that we have some new individuals joining us. Very sad that we have a couple that are leaving us, but I thought we would take this part of the agenda to introduce ourselves, tell each other a little bit about ourselves, just to kind of orient everyone to who's on the subcommittee. I know Chelsea Cheatham is first on our list, and I just wanted to share that she's not leaving us. Chelsea is going to be moving to the Prevention and Harm Reduction Subcommittee. So she's still a full member of the SURG. She's just going to be shifting to that subcommittee due to her expertise in that area as well. So we're very grateful to everything Chelsea has done on the Treatment and Recovery Subcommittee. She's been with us for a long time. So we really appreciate her. Chelsea, I'll turn it over to you to share a little bit about yourself.
Sure. Thank you so much, Chair Shell. My name is Chelsea Cheatham, and I am representing harm reduction on the SURG. And I had worked with a very dear friend of mine, Rick Reich, and we started the Track B Exchange, which is the harm reduction syringe exchange program that is based in Las Vegas, Nevada. We started that program in 2016. And I still support them, but currently I am working in prevention. I work for the PACT Coalition for Safe and Drug-Free Communities, which is the Substance Use Prevention Coalition that serves Clark County, Nevada. So I will be moving from this subcommittee to the prevention subcommittee. As Chair Shell said, it's been great serving on this subcommittee. I think we're doing wonderful things, and we've got some really good recommendations that we're putting forth. So I look forward to hearing from all of the new members, and I'm always here if anybody has any questions about anything related to, my previous work in harm reduction, anything that's going on with prevention. I will be here to support the subcommittee. Thanks.
Great. Thank you so much, Chelsea. Next up is Stephanie Cook. We're so excited to have Stephanie join us. She was just recently appointed to the SURG and was very willing to join our subcommittee. So, Stephanie, welcome aboard, and I'll turn it over to you.
Hi, thanks everybody. Thanks, Chair Shell. My name is Stephanie Cook, and I serve as the State Opioid Treatment Authority within the Bureau of Behavioral Health, Wellness, and Prevention within the Department of Human Services. So in my role, I'm also the Deputy Bureau Chief, and I oversee all the substance use programs in our bureau. So most of the money in the state as it relates to substance use prevention, treatment, and recovery comes from our bureau. There are some other agencies that have some money at the state level, but most of that is coming from us, and our bureau serves as the single state agency for substance use services. So a lot of my work is overseeing prevention, treatment, and recovery services. My background comes from substance use treatment, really helping the state lead that way back in 2016 as it related to outpatient services. And so I'm here on this committee and very excited to be here.
Well, thank you, Stephanie. We're very excited to have you with us. So thank you for all your expertise that you bring to us. So very excited to work with you. Next up is Dr. Leslie Dixon, and I wanted to mention before I turn it over to Dr. Dixon how grateful we are to her many years of service to our subcommittee and to the SURG. Dr. Dixon is resigning from her appointed position on the SURG, and we told her she's not going to get very far away. She's just been a huge champion for us, and we've really appreciated her engagement through the years. So, Dr. Dixon, I'll turn it over to you.
Hi, thanks, Chair Jill. Okay, yeah, so I've been doing addiction psychiatry for many, many, many years, and what has precipitated this is that the company I work for, BHG, I did retire from the end of August, and so I really not exactly still really fit the criteria here to be on this committee. But the other thing is that I am planning to relocate home, which is San Diego, sometime next year. So, but I've enjoyed this very much, and I'm going to miss this. I was reading the minutes. I was just telling a few of them before we started. I was reading the minutes, and some of the proposals sound like, oh God, I would love to be involved in that. But anyway, it's time to turn it over to the younger folks. So I'll miss you all, and I'll miss these meetings. So thank you.
Well, Dr. Dixon, thank you so much. And I did not know you were going to be relocating next year. So we wish you very well in that as well. But anyway, thank you, Dr. Dixon, for all your participation, you and Chelsea both. So thank you both.
Uh-huh.
Next is Assembly Member Rebecca Edgeworth. Although she's not here today, I just wanted to share that she was our member of the Assembly who was appointed by the Assembly Minority Leader. So she was just recently appointed to the SURG and then was very willing to join our subcommittee as well. And then we have Assembly Member Heather Golding. She was appointed several months ago, I think at least 6 months ago, Kelly. I believe so. And then subsequently wanted to join our subcommittee. And she is the one member of the Assembly who is appointed by the Speaker of the Assembly. So we're very grateful to both of our Assembly members, making time for this subcommittee, and hopefully they'll be able to join our subsequent meetings. But as I shared at the beginning, I'm sure they've been very tied up in the special session over the last several days that the governor called in Carson City at the Capitol. Next up is Giuseppe Mandel. We're very excited to have Giuseppe join our subcommittee. He was also recently appointed to the full surge and then subsequently was willing to join our subcommittee. So very excited about the passion he brings to our subcommittee. So Giuseppe, I'll turn it over to you to share a little bit about yourself.
Thank you, Steve, and thank you, everybody. Giuseppe Mandel. I'm a person in long-term recovery. Worked in law enforcement before that. Before ended up in being homeless and on the streets due to opiate addiction. I also lost a brother to fentanyl 4 years ago, which drove me into this work. I work as a community engagement specialist for Vogue Recovery Services, which is an LA health group, help navigate people getting into treatment. And I'm excited to be a part of it. I actually have gotten syringes from Chelsea, and she was working at Track B back in the day, well before treatment. So ran into her later on, and Dr. Dixon, I've been tooling around and learning from you for a long time. So look forward to it, and thank you guys for having me.
Well, thank you, Giuseppe. We're very excited to have you on board with us and look forward to working with you as well. So thank you.
Thank you. And sorry about my camera. This has just been a day of technical difficulties. So
Oh, no
we're
worries.
through it.
We know you're there. We can hear your voice. So thank you. And then just to share just a very quick summary about myself, I always like to start with the fact that I know I'm not originally from Nevada because everyone can tell by my accent. I've lived in Reno for 16 years now, but never lost the accent and probably never will at this age. I've done a variety of things in the state. For a few years, I commuted to Las Vegas from Reno, which was really fun. I did that for about almost 6 years. I opened Desert Parkway Behavioral Hospital in Las Vegas that's right across the street from Sunrise Hospital. And I was the CEO there for a few years. And then while I was running Desert Parkway, the company let me open Reno Behavioral Healthcare Hospital. So I opened that one and served as the CEO. And then for the last 5 years, I was the VP of Behavioral Health at Renown Health. And I'm now focusing more on my nonprofit that I started about 18 months ago called the Behavioral Health Association of Nevada, which is working to build a coalition of behavioral health professionals, but also allies around the state. So that's kind of a little summary about myself. But again, we're so excited about all of our subcommittee members. Very sad to see Dr. Dixon go and Chelsea move over to the other subcommittee. But again, very excited about the work to come with our subcommittee. We have accomplished quite a bit in the last few years, had lots of great discussions, great ideas and recommendations that we've put forward. So very excited about what the work that the subcommittee will continue to do in 2026 and beyond. So just looking forward to working with all of you. Okay, so that will conclude item number 4. We will move on to item number 5 on our agenda, which is a follow-up discussion related to a proposed recommendation that Chelsea Cheatham actually submitted, and then our presentation that occurred back in July. And Chelsea, it probably would be helpful if you wouldn't mind giving another quick summary of your recommendation, just for those that are new to the subcommittee, that they can hear more about what it is you brought forward, which is great, by the way. So can I turn it over to you if that's okay?
Yes, you can.
Thank you.
Thanks.
And before Chelsea goes, if I may, this is Kelly Marshall for the record. I just want to note that in the posted materials, we have a 2025 SURG Treatment and Recovery Subcommittee preliminary recommendations. So you can see there that recommendation number 1 was submitted by Chelsea. It was submitted on August 20th, and there's much more detail in that document. So the treatment and recovery members would have received this as part of their pre-meeting packet last week, but it's also posted on the SURG website, and people can also go to the site after this meeting and pull down a number of the materials that we have. So I just wanted to note that, Chelsea, we do have slides as well based on, your previous presentation. But I wanted to note that there is more detail, and we do have all of the additional research that you were requested to do that you did in fact do. We have those studies as well that we can pull up for discussion. And I think the point being, one of the questions for the subcommittee and for you, Chelsea, today, but I think also for the subcommittee, is whether this recommendation should move forward in treatment and recovery, or if it's one that should follow you as you go to prevention and harm reduction. And Dr. Dixon, in our 2 previous meetings, weighed in and was very interested in this research, as was Assemblymember Golding. So I think we're trying to resolve that today, since this would be the last meeting that you would actively participate as a treatment and recovery member.
All right, so my recommendation is shown on the screen. I'm recommending that we do a retrospective or prospective, but I believe retrospective would probably be the best way to do this study on looking at mortality rates and relapse rates after someone gets out of opioid detox, and then using that information to develop best practices for continued care after people leave detox. So as Kelly mentioned, there were 4 studies that I had attached that were attached to the agenda that went out. And I'll just kind of go do a little brief overview over those studies. And they just the first one is a study called MOUD Saves Lives, especially after 60 days, and the longer the better. What was found in that study is that there is a 60% risk reduction if people are on MOUD for 60 days after they leave detox, and that there could be a 10% risk reduction for each additional 60 days that they're in care after they leave detox. The second study is the new and emerging opioid overdose risk factors. That has a lot of information about just lots of ways that we can reduce people's risk of opioid overdose. Includes some harm reduction information in there. But the takeaway that I saw from the MOUD section of that article is that medically managed opioid withdrawal has, which is detox, has a 90% rate of relapse within a year. So one of the suggestions is to have people start MOUD after they leave detox. The third study is the association between mortality rates and medication and residential treatment after inpatient medically managed opioid withdrawal, which was a cohort analysis done in Massachusetts. And the takeaway that I saw from that study is that among people who have undergone medically managed opioid withdrawal, MOUD, residential treatment, or a combination of both MOUD and residential treatment reduced their mortality rate compared to people who did not receive any treatment after they left detox. And the fourth study that was attached is the receipt of opioid use disorder treatments prior to fatal overdoses in comparison to no treatment. And that was a study done in Connecticut between 2016 and 2017. And the takeaway from that study is that exposure to methadone or buprenorphine after detox reduced the relative risk of overdose by 38% for methadone and 34% for buprenorphine. So there have been multiple studies done around the country that have shown that, when people are leaving that medically managed detox, that being on some sort of medication for opioid use disorder helps to reduce their risk of an overdose, helps to reduce the risk of overdose death, which is why I believe a retrospective study would be something that would be the best use of our this recommendation here in Nevada, but I would love to open this up for discussion and hear from everybody else.
Do any of our subcommittee members have any thoughts or comments for Chelsea regarding this recommendation?
Giuseppe, for the record.
Yes, Giuseppe.
Does it give a time frame on when they're out of treatment and how long they've stayed on the MOUD, and does it gather any numbers of if they've ever come off of it?
So after reading all the studies, the 4 studies that were attached, though I think the best one that is kind of answering your question is that one that's MOUD saves lives, especially after 60 days. What it showed is that there was a 60% risk reduction if someone was on MOUD for 60 days after they left detox, and there was a 10% risk reduction for each additional 60 days. I don't know. I didn't really read through all of the studies and write down how long they followed people retrospectively. But I think that's something that we could definitely discuss if we want this recommendation to move forward, is really to figure out how this would look, and how long we would, especially if we're doing a prospective study, to see how long we would want to follow people after they get out of treatment, or retrospective, what we would probably be able to do. And I'm unsure how to do this. I'm sure there's people on this committee that might have some better ideas, is to look at death data and compare it to the treatment data and see how long someone was out of treatment. If the before they may have overdosed after treatment.
Yeah, and Giuseppe Mandel for the record. I really appreciate all the hard work that you did on it, Chelsea. I did. And it just I just think it's important numbers if we see how long they're staying on MOUD. And for us more laymen's, when you say 60% reduction, where do those numbers come from and exactly what does it mean?
Sure. Let me actually flip through the study real quick and see. And see if I can give you some better information, Giuseppe. Okay, let me pull up that one specifically on my screen and take a look at it. There we go. Okay, so for this study, Giuseppe, they said that the follow-up period was limited to only 12 months and required the presence of an opioid use disorder diagnosis and Medicaid claims. Let's see.
And is that only Medicaid claims, not private insurance or?
No, it looks like when they did the study, they were doing it retrospectively, so probably that was the best place that they were able to follow patients from, was looking at the Medicaid claims and looking at opioid use disorder diagnosis.
Yeah, well, you've encouraged me, Chelsea, to look for another study to see long term.
Yes.
To see how successful it is long term, since I know the last 4 probably overdoses I've known of this year have all had like 2-3 years sober, and then had gone back out and died. So it'd be interesting to see if they got off MAT, if that was the problem, or if they were never on it.
Yeah, and that's something I can even look and see if I can find additional studies as well, that look at this more long term.
Did that answer your question, Giuseppe, or anything else you have to share?
Oh, yep. I apologize. Yes, no, that answered it. Yeah,
Okay.
thank you.
Okay, good. Thank you. Anything to add to that, Chelsea? Or?
No, nothing to add. I think I can look around and see if I can find more studies that will help answer that question, to see if there are any longer term studies that follow patients for several years. And then if I do find any, I'll send them to you, Kelly, to send out to the group.
Great.
But
Thank you for the oh, go ahead, Chelsea.
Oh, sorry, I was just going to say, I also think if we did a retrospective study, we could kind of create our own time limit. So if this is something that we wanted to move forward, we might be able to say that, we would like to look at this long term and maybe have a longer time limit.
So this is Dr. Dixon. There was a study, this is on suicide, but there was a study a fellow did up in, he's in Minnesota, I think. Anyway, and what he did was he was interested in people who came to the emergency room having made a suicide attempt but survived it. And then they were followed for a while to see how many went into treatment, were recommended into treatment, how many did not go into treatment and how many eventually suicided again successfully. But it's really challenging to figure out where you're going to get your data from. His was emergency room records and coroner's data, and some way they figured out how to follow up people in the going to a clinic, because everyone's always referred to clinic, but not too many go. And so that's the same problem we have here, is that my experience taking care of these folks is that, and I was, like I said, was saying earlier, I wish I'd remembered to call the clinic I used to work at. We have a terrible rate of returns. People they get referred out of them, from a detox, or they're self-referred or whatever. And if they make the first appointment, of course, that would be one interesting. Did they make an appointment? Did they keep the appointment? And then did they come after the first initial evaluation? And then the return after that first initial evaluation is pretty terrible. And so it's, what are you going to do? I mean, are we going to get their permission to call them and see what happened? But anyway, what I was just thinking, practically speaking, is this something you're thinking to put into a little bit more of an organized form, and then try to get what is it, the Fund for Resilient Nevada, to put out an RFP to get some people to apply to do this study? Is that what the next step would be?
Chelsea Cheatham for the record. I think, Dr. Dixon, that's a good idea for us to really kind of form how we want the study to look. I mean, I think that if we were doing a prospective study, we could do it exactly like you're suggesting, which is to get permission from people when they're finishing their detox treatment, to follow them afterwards, or doing a retrospective study. And with a retrospective study, I think we would just be looking at data sets that are currently available. And then we would be able to really look at, any time frame. So that could include more of what Giuseppe just mentioned, which is, looking at a longer time frame to see, to look at, what happens if someone is, out of treatment for 1 year, 2 years, 3 years, et cetera. But I think, with this recommendation, we can maybe, as a group, if we're all talking about it, we can really figure out exactly like what we would like to do with it. I think that that's a really good suggestion, though, is to make this into something that could be like a study that is funded in some way.
Yeah. Well, and then I think what you would want would be actually to find maybe some graduate students at one of the schools to actually do, really write it up as a grant. And then, this is going to have to be approved by an IRB somewhere. I'm not sure where, which one of the ones we have here. So it's a long-term process to get something like this off the ground, but it's always good to have a real enthusiastic researcher who wants data and publications, which I'm sure is where all these papers that you had here came from. Is somebody is getting something out of doing these research. And so, of course, we need money to pay research people. But anyway, but I'm not sure. I don't know really at the university level what programs might even have such a candidate. That would be another thing. We don't have much in the way of university people on these committees. So anyway.
Thank you, Dr. Dixon. I see Stephanie. Oh, go ahead.
No.
I see Stephanie Cook with her hand raised.
Yeah, Stephanie Cook for the record. The state, I'll just say a couple things. The state's doing a lot of this work right now. We're working on a dashboard to look at who is on MOUD and what services are they seeking before and after getting on it. So we're looking at implementing that at a state level. And I think what might be helpful is then diving into something, what is a gap that we see from that data. Once we pull that data together, I'm really interested in knowing when MOUD is being accessed and when it is better, like better ways for it to be accessed as well. So as we look at getting those data sets, I've got a team already working on pulling some of this data together, really looking at residential treatment, like Chelsea said, the prison system, like just pulling into different access data points, and most of the time we look at Medicaid data because that's the largest data set anybody usually has. Now that the Nevada Health Authority has access to PEB data, they're working on they call it something, I don't know. It's like one single payer source kind of data set. So the state will have access to that as well. So it's not just Medicaid data, it's data on state employees too, and the health insurance exchange. So having all that data in one place will be cool, I think, as the Nevada Health Authority moves forward. Um, but I think Kelly too, with the question of is this treatment or is it harm reduction or prevention? I think, when we look at, accessing MOUD and reducing overdoses, we're looking at it from like a treatment standpoint at the state, really focusing on getting people the treatment they need, to reduce those overdoses. But that's the lens we take when we're looking at MOUD services.
Giuseppe Mandel for the record. Stephanie, I'm so glad that you're on this call, and Chelsea, and this is why I love working with you brilliant minds. So, I mean, one thing, and especially if somebody from DHHS is on here, and I think one of the problems that we're having in the state is tracking data and numbers, especially by Medicaid or um, the Affordable Care Act, the Health Link data, and that's all you're getting, and therefore it's not properly showing us the right numbers. Where a lot of your ODs are commercially insured patients, or in fact, majority of them are. And the one gap that we have, even in the Medicaid area, is not going to show you the accurate number to where treatment, 30-day residential per se, the success rate there versus the detox spin dry right into outpatient, which is generally what Medicaid does, and what that risk would be lowered as far as ODs when you have your standard detox 30-day, 90-day, and from there. And if it was on MOD, and I'm sure, like Chelsea is brilliant enough to where retroactive is probably the quickest and fastest way to do a study where you could save lives right now, because you have several people. I'll put my name in that hat as well, of lived experience, who are out there. And if you find out a way to reach us, we'd be happy to turn over all our records to you to save lives. You could do a complete retroactive study, and there's plenty of people that be guinea pigs to do it, if that even works amongst the studies. Just a suggestion or advice.
Great. I'm very excited to hear about the data that Stephanie mentioned. I really appreciate you bringing that up, Stephanie. That's exciting. Um, Chelsea, to go back to you, what are your thoughts about? Well, let me just say that in our last subcommittee meeting, we had talked about continuing to vet this recommendation. And so just knowing that, what are your thoughts, Chelsea, about whether this recommendation should remain with our subcommittee or follow you? Have you had any thoughts about that?
I have, and I think this recommendation would fit best with this subcommittee. I was really happy to hear when Stephanie mentioned that you all are already collecting some data related to this. And so I think that this would fit best in this subcommittee.
Okay. Thank you for that, Chelsea. How about our other subcommittee members? Does anyone have any strong feelings one way or the other? Okay, so it sounds like the consensus is to keep Chelsea's recommendation with our treatment and recovery subcommittee. And if that's the case, we don't really have to take any further action on this recommendation at this time, unless other than just continuing to vet this recommendation. One thing that we didn't share at the beginning of this is that our recommendations are not actually due to the full SURG until August of 2026. The SURG has changed the timeline on those recommendations being due. So we actually have more time to consider other recommendations and then figure out what our final slate of recommendations will be to the SURG. And we do ask that each subcommittee member bring forward at least one recommendation. So if any of our new subcommittee members need assistance with any of that, please let Kelly or myself know, and we can certainly walk you through that. But those are just some of the details on that. So unless no one has any other comments about this recommendation, we'll keep this with treatment and recovery and then continue to vet this as we have been. Anything else we need to cover on that, Kelly?
I don't believe so. Kelly Marshall for the record. I think one question would be, as we continue to shape or vet the recommendation, it may be that somebody wants to co-sponsor that recommendation, so that Chelsea isn't requested to come back every time we're talking about the recommendation. So I think that's something that this subcommittee could consider. And Chelsea, I assume that you would be amenable to a co-sponsor on that recommendation.
I would, yes.
So Chair Shell, I think that's probably not for today, unless somebody wanted to make a motion that they would co-chair and continue to, or co-sponsor and continue to champion that as a recommendation. In the absence of that today, I think we've done what we needed to do in terms of figuring out that the recommendation being vetted can live here.
Thank you, Kelly. Does anyone have a motion to that effect today? Or if not, we can place this on the next month's agenda, the agenda for the next meeting.
Does this agenda item allow us to make the motion? Yeah.
That's a great question.
Yeah,
Thank you.
good question, Stephanie. What do you
Thanks
think,
for
Kelly?
keeping us honest. Actually, let me pull up the agenda itself.
For possible action.
Yeah, possible action.
Okay, good. So on that note, yes, we could entertain a motion regarding this recommendation. If anyone has a motion to make.
This is Stephanie. I'd recommend making a motion to co-sponsor this with Chelsea.
Thank you, Stephanie. So we have a motion from Stephanie. Do we have a second?
Giuseppe Mandel, I second.
Thank you, Giuseppe. Any further discussion regarding this? All those in favor, please say aye.
Aye.
Any opposed? Motion carries unanimously. So thank you, Stephanie. We appreciate you agreeing to work with Chelsea and be the co-sponsor of this recommendation. And thank you, Chelsea, for bringing this forward. Okay. So also under this agenda item, I wanted to mention a recommendation that I submitted on June 17th of this year. This is regarding hospital emergency rooms and the use of peer support teams. I've personally had peer support teams in the ER that were grant funded. And while we've made great advances with Medicaid reimbursement, we still have a lot of payers that do not reimburse for peer support. And so my recommendation was to encourage the state to figure out how to incentivize hospitals to have peer support teams in their ER, either helping offset some of those expenses that Medicaid, and others can't cover, or for the uninsured and so forth. So that's my recommendation. We're still in the process of vetting that. We do have some presenters in mind that we're going to bring in regarding this recommendation in a future meeting. But if any of you have any ideas, particularly our new subcommittee members, if any of you have any ideas regarding this, it would be great to hear those ideas. Again, this is just from my own personal experience in trying to operate these teams. We stood up a team in the renowned health system, and unfortunately, the group that we were contracted with, did not have additional grant funding to continue the operation. So we had to disband the team, and that was very unfortunate. And I've seen the positive impacts these teams have in the hospital ERs, and I know ERs truly need this. I know there's some great work being done by Dr. Kelly Morgan at Valley Hospital in Las Vegas, and we've talked about maybe having her come back and talk to us about her experience with the team in that ER or in those ERs in Vegas. So that's one idea, Kelly. And then, Kelly, there was someone else that we had talked about. I believe it was someone at CASAT that we had talked about possibly bringing in as a speaker, but we can save that for another time. Any questions regarding this recommendation? Any thoughts or?
Well, did we, did Patrick Kelly ever get invited to come?
Yes, that's the other one, Dr. Dixon. Yes, thank you for reminding me. We had talked about Pat Kelly, the CEO of the Nevada Hospital Association, joining us at one of our future meetings, just to hear his perspective on, the hospitals that he represents and whether or not he thinks they would also be on board with this. I suspect they will be, because we've got a lot of evidence showing, the success of these types of teams and that lead to successful outcomes once these individuals are out of the ER and into treatment and recovery. So, yes, thank you, Dr. Dixon. Pat Kelly is definitely the other one that I had in mind.
So Kelly Marshall, for the record, so Pat Kelly was definitely listed as a follow-up, and follow-up has been done, but just based on today's meeting and I think everything else that's going on in the state, we weren't able to confirm a presentation today. I did not have Kelly Morgan listed only because I believe Dr. Morgan has presented to this subcommittee previously, also presented recently to Response. I believe, I know Terry Kearns is on, and Dr. Kearns, if I have that wrong, if it wasn't Response, if it was prevention and harm reduction, please let me know. Go ahead.
I just thought of Dr. Morgan Kelly because I know she's presented before, but I don't think we actually had her present about the use of the peer support team. But that's just an idea. But that's the reason why she came to mind.
So I'm happy to add Dr. Morgan for the follow-up, as well as Pat Kelly for recommendation 2, and put it on the agenda for your next meeting.
Thank you, Kelly. And on that note, I wanted to ask Stephanie if she may be aware of any other hospitals that are utilizing peer support teams at the moment that we may not be aware of that we could also invite.
Giuseppe Mandel for the record.
Yes, Giuseppe.
So this is actually my job. I work directly with the peer navigators and all the ERs. With Chelsea and Spencer, sorry, Chelsea, Spencer is now going to be an employee of us. But that's because he's done such a great job. And West Henderson Hospital, but Valley Hospital has the peer navigators, as well as Henderson Hospital. And West Henderson Hospital utilizes myself a lot, and we keep pushing the warm line, and for them to be able to get in to there as well. So I do have all the contacts, but Chelsea Cheatham has them all because they've all worked for her.
Giuseppe, do you know if Dr. Morgan is, working throughout the entire Valley Health System or just Valley Hospital by chance?
So Dr. Kelly Morgan is the medical director for Las Vegas Fire and Rescue, and she also is an ER physician for Valley Hospital.
Okay. I was just curious if she might be able to give us a perspective. I'm glad to hear that there are several hospitals within that Valley system that, are using these services. And so I was just curious if she could give us her perspective from the whole system and not just, the one hospital.
Dr. Morgan is a very busy woman, but I'm sure she would make time for it.
Okay. Thank you. And if anyone else thinks of anybody that, Kelly could reach out to as a possible presenter on this, we'd certainly be open to that.
This is Chelsea Cheatham for the record. There's someone that we work with really closely at Valley Health Systems, and at Valley Hospital, and she has been helping us with getting the peers onboarded, badged, everything. So I can get Kelly her name and information. I think she would probably be someone who would be able to speak really well on this subject.
Okay. That would be great, Chelsea. Thank you.
This is Stephanie Cook for the record. I think we're struggling in Northern Nevada. I've got a couple of folks looking at hospitals in Northern and rural Nevada, and I think that's kind of where we're struggling is up here.
I know that Track B had some great data during the time that I had them at the Renown ERs, but I don't have access to that data any longer, not being at Renown. But I know Track B was capturing a lot of great data. So that may be something to keep in mind too, for Northern Nevada. Okay, if there's not any other further discussion regarding this recommendation, we don't have to take any further action on this one. This will still sit on our list of recommendations that we can continue to vet into 2026 before we make our final recommendations to the surge in August of 26. So that will conclude item number 5. We'll move on to item number 6, which is an update on and a discussion of our previous treatment and recovery subcommittee recommendations. And as we had shared in our last meeting or last few meetings, we have the option as a subcommittee to move previous recommendations or continue to move them forward and have those as part of our recommendations next August. We can vote to make changes to those previous recommendations and then resubmit them as new recommendations next August. So we have a variety of options that we can take. We don't necessarily have to act on those today unless someone makes a motion, but just wanted to put that out there that we do have some options. So we had 4 recommendations from 2024 that we brought to the full surge. And I'm very excited that Maddie Larson is here today. She brought forward number 2. We're going to start with number 2, and then I'll go back and cover the others. But she brought forward number 2 that subsequently became, well, simultaneously was introduced in the legislature as AB 394 and has now been signed by the governor. So tremendous work there. We were so excited about Maddie's passion around this and her great ideas, and I'm not even doing it justice. So Maddie, not to put you on the spot, but if you could just give us a quick overview
Yeah,
of that
absolutely.
BDR and the great work around that and the implementation of it as well.
Yes, thank you so much. This is Maddie Larson for the record. Thank you, Chair Shell, and all the new members of the Treatment and Recovery Subcommittee and the old members. It just feels like yesterday that I was on here telling you guys about this BDR last September, and now it's in NRS, and it's being implemented as we speak, not just ink on a page, as the best say, but in real life it's happening, which is super cool. So thank you so much for being so supportive of this idea and putting it in the 2024 annual report within the surge. To be able to go to the legislators and say that it's in the annual report from the surge was huge. It really got their attention, I feel like, and it's great to show that we can really operationalize these recommendations as they get put forward in the annual report. So I'll just basically the rundown of this is to have NSHE-wide, which is the Nevada System of Higher Education, naloxone accessed across all 8 institutions. We really wanted to make sure that each institution had the opportunity to tailor an emergency response plan to address opioid overdoses within their institutions. Our geographic distribution is so unique in Nevada, and we want to make sure that what was happening at UNR didn't need to happen necessarily at Great Basin out in Elko. So we really allowed a lot of autonomy in that, which you'll see in this recommendation that you guys put forward. And a lot of different places that the naloxone can sit and different training opportunities. So we were in such a sweet spot last year with this because we were in the interim time. So we were able to get a ton of stakeholder engagement and get all the right people and all the right players. And I'll say Assemblywoman Tracy Brown May was a champion in this work. She's a champion in opioid harm mitigation, and she was the primary sponsor on this bill. As well, we worked a lot with NSHE, the government affairs team, the Northern and Southern Police Commands, the Board of Regents was big in this, as well as the Chancellor. And then also Stephanie Cook from DPBH was such a good champion in this. Thank you so much, Stephanie, for having so many meetings with me last year and getting this happening. And then really, we wanted to talk with all the different NSHE institutions institutions too, so that was huge. But really, just what happened in legislative session is this was referred to the Assembly Committee on Education. It passed out of the committee and the Assembly floor unanimously. Then it got referred to the Senate Committee on Education. It got passed out unanimously with one revision, which was to add 3 joint sponsors, including Senator Titus, Senator Rogich, and Senator Buck. So this legislation was really no nonsense bipartisan policy that we push forward. So really the nitty-gritty updates are that currently, the NC-wide has emergency response plans, and this is in it. There is actual words and actual things that is happening, which is cool. That sits in the organizational resilience policies that they have. So this looks like what is happening during an overdose, calling 911, administering naloxone, and also really emphasizing compassionate overdose response and rescue breathing as well. We had to get that in there, as well as what the emergency coordinator is going to do, stock the naloxone, document what's going on. And really, this is so that we can shift the narrative around opioid use and drug use in general to keep people safe and keep people alive. Another really cool thing that this emergency response plan does, there's a clause on protecting students against any disciplinary action that cannot be taken against them for obtaining the naloxone or using the naloxone in good faith. That was really taken from Dr. Wagner and her research team and students that say that they were scared to take the naloxone and be seen taking it. So all that's in there, it's actual words. And then next, I've really been working with different organizations to talk with each NC institution to actually implement this and get them the naloxone that they need, and working with their community coalitions throughout Nevada. That way we can cross county borders if we need to and just get them the actual tangible naloxone. Finally, we're really trying to get it in the university administrative manual, which is all that sort of red tape lawyer language, I feel like. I don't know, but we're going to work on that. I have a meeting actually in the next few weeks to get that going on. And then just a really quick update on like a few of the institutions that are actually doing this. This is in real life. UNR, of course, has been such a pioneer in this. They have the ability for students to get the training and then get it from 3 different distribution points on campus. UNLV is offering free naloxone that they can get through the Student Rec Center. And then UNLV is also offering fentanyl test strips, which is great, a little cherry on top of this work. TMCC is just modeling right after UNR, which is great through the Canvas training, and they can get the naloxone at the counseling center. There's also training going on for faculty and staff. WNC, Western Nevada College in Carson, and in those different quad counties up here in Northern Nevada, they've been a huge champion in this work since the get-go. They have their training looking within their emergency response teams, their facility and custodial personnel, and then they're also opening up their AED CPR first aid training to all their faculty and staff on campus, which includes that naloxone training. And I'm really trying to work with their partnership Carson City Coalition to get them the naloxone. And then DRI, which is the Desert Research Institute, is not really a regular college setting, I don't think. But I was like, I wonder what they're going to say about this. And they were super excited. They're like, we're a part of Nevada's Recovery Friendly Workplace Initiative. And they have multiple boxes set up around their campuses that they restock as needed, which was awesome. And then my last 3 that I'm still working on. So if you guys have any contacts or in with the CSN, College of Southern Nevada, Great Basin College, or Nevada State University, those are the ones I'm still working on, but little by little. We just got this passed this year, so we're really seeing tremendous work, and I just appreciate you guys. That's my update.
Maddie, thank you so much for all of your efforts in this. This just shows it's just a prime example of how, hard work like this can really pay off and is now, a signed bill by the governor. So just huge kudos and congratulations. So thank you so much. We've really appreciated working together on this and all of your hard work on this around the state. So thank you so much for being here today. Any
Thank you so
questions
much.
or comments for Maddie? All right. Well, thank you so much again, Maddie. We really appreciate you. Going back to item number 1 or recommendation number 1, this is one that I had recommended last year that our subcommittee then chose to take to the SURG. There hasn't been any action taken on it as far as I know at the state. We're hoping something may come from it in the next legislative session, but I was very concerned that hospitals are still excluded from hiring peer support specialists that have a felony within the last 5 years. and I felt strongly that that should be lowered. And so our subcommittee, agreed as well. And so our recommendation was that legislation be considered to lower that requirement to 3 years, a felony within 3 years, as long as that individual was not convicted of a violent act or sexual exploitation. So this is one that we can continue to, we can vet again this year or in the next year if we'd like. We can make amendments to it, but just wanted to know that one's still sitting out there. I know that's still a stumbling block for a lot of hospitals. I personally had several peers that I wanted to hire but couldn't because of that requirement. And we have a lot of great peers out there that have been maintaining their recovery, for quite a while, but just don't meet that 5-year requirement. So, any questions or comments about that one at this point? Okay, so moving on to number 3. This was a recommendation made by Chelsea. And Chelsea, I don't know if you'd like, would you like to just give a quick snapshot of your recommendation from last year?
Sure. So my recommendation is to support access and linkage for treatment of trauma, specifically for people who with substance use disorder, people who have overdosed, and also surviving family members after an overdose fatality. So really, this would be supporting training for healthcare professionals to identify trauma after overdose-related events, and then also to address that trauma.
Great. Thank you, Chelsea. Any questions or comments for Chelsea? And again, that's a recommendation that we could continue to look at this coming year and, make any possible amendments that we might want to as a subcommittee. But that was one that was also taken to the SURG this past year. And then number 4, and Kelly, I apologize because I had totally forgot that Dr. Morgan's, I knew her presentation was around the bridge program, but in my mind, I wasn't linking it to peer support like I should have. And so this one is very similar to the recommendation that I've made this year. We had Dr. Kelly Morgan come to our subcommittee meeting last year, and her recommendation was that DPBH look at a funding mechanism for hospitals or providers to enhance their bridge programs by incorporating peers, which I think we all agreed, was excellent. And that's why we moved it forward as a recommendation to the SURG. In my recommendation for this year, I was thinking more along the lines of not necessarily going down the bridge program path, but just peers and, for general services in the emergency room. So we can, going forward, we can talk about how to incorporate this past year's recommendation with the one I've made for this year. There are a number of ways we can look at it. We don't necessarily have to do that today, but I just wanted to put that out there that what I proposed this year is very similar to what we had made as a recommendation this past year. Any questions or comments around that one as well? Okay, well, that will conclude the discussion on our 2024 recommendations. Moving on to item number 7, this is a discussion of our proposed 2025 Treatment and Recovery Subcommittee recommendations. And I think here, Kelly, we've already discussed the 2 recommendations we currently have on the table. So unless any of our subcommittee members have any other further discussion regarding those 2, we can move on from this agenda item. Does anyone have any comments regarding this agenda item? Okay, we'll conclude that item and move on to item number 8. This is a discussion of our upcoming presentations and topics, and I'll turn it over to Kelly. I know you've been working tirelessly, Kelly, to find us some presenters for future meetings. So I'll turn it over to you.
Well, thank you so much. Kelly Marshall for the record. So as of right now, I have Pat Kelly on the slate for us to do follow-up related to his weigh-in of the Nevada Hospital Association. And then I have notes that there may be folks from either Valley Hospital or the West Henderson Hospital that could talk to us about the actual use of peers, cost of using peers, how follow-up happens. And so I'm anticipating folks will get me some names so that we can add that to our tracker for presentations at the next treatment and recovery meeting. And then I have a question mark about Dr. Morgan. And so I'm not sure, Steve, do you want me to pursue Dr. Morgan, or do you want to wait and think about synthesizing those two recommendations and then deciding on presenters?
I'm thinking maybe wait, Kelly, and speak until we figure out how to synthesize those. And I'm thinking too that it might even be great to find somebody from the Valley system that's been involved with this on Dr. Morgan who can speak to the cost of the team and the benefits as well. I think that would probably be helpful to know as well, or to just explore further, which, speaks to why we need that funding mechanism in place.
So I would say if anyone has an idea of somebody who can talk about cost benefit at Valley Hospital or any hospital system that is actively using peers, I think that would be great. And I'm happy to follow up. I think the other question that we would then have just generally for subcommittee members would be if there are ideas that you are that you're considering submitting as a recommendation and you have a presenter that you would like to bring forward, or perhaps you don't have a recommendation fully developed, but there's a presenter that you think has information or ideas that the treatment and recovery subcommittee should know about in case they want to submit a recommendation. So I think we still have that kind of open call for presenters beyond the ones I just mentioned. And I entertain any suggestions now, or people are always welcome to email me. I will note that I'm stepping down from supporting the SURG on December 31st. I'm retiring, and so this is actually my last subcommittee meeting as well, and it's just been delightful to work with all of you. Somebody else from SEI will be staffing this subcommittee moving forward, and all of this is documented. Laura will be our continuity person, as she has been with us since the beginning and has happily and faithfully supported me, the chair, and all of you. So please continue to email me ideas, and we will follow up with them and ensure that there's no loss of continuity.
Well, Kelly, on that note, I'll just go ahead and say it now that thank you so much for everything you have done for treatment and recovery, the SURG, and so on. I was hoping that maybe I was wrong in thinking this was your last meeting. I was hoping maybe you decided to extend that, but we wish you nothing but the best, Kelly, because you've just been a superstar for us and keeping everything organized and keeping us motivated and on schedule. So thank you so much for everything you've done, Kelly.
Well, thank you. And I would just say that it's actually a measure. I am continuing to work at SEI on a part-time basis, very, very part-time basis, but it's a measure of the efficiency and the functionality of the SURG that I had no concerns about stepping down and somebody else taking over. I think the infrastructure that we have, the strength of the expertise of our subcommittee and our SURG members, the processes, your role as chair, and also the leaders that we have across the other subcommittees. I mean, SURG is just such a strong and beneficial committee for the state of Nevada. So I've been proud to be able to help stand it up and support it and have no worries about exiting.
Well, thank you so much, Kelly. Excuse me, anything else related to number 8 before we move on? Okay, moving on to item number 9. This is to discuss our report out at our next SURG meeting, which will occur on January 14th of 2026. During that meeting, each subcommittee member makes a brief report. So unless anyone has any other ideas, I will be reporting on our 2 recommendations that we currently have on the table, as well as giving a brief overview of our newest members. And then I think that's probably it, Kelly, in terms of new business items to share at the next meeting, unless anyone has anything they want to recommend that I report out on.
Chair Shell, Kelly Marshall for the record. I think it's helpful for other subcommittees to know that we had Maddie come and provide an update, that you provided updates, so that that tracking of implementation of previous recommendations and then also reconsideration of those recommendations. It seems to me like in addition to the two recommendations we talked about today, there may be some viability, right, of integrating the bridge program and the peer recovery recommendation, and also potentially re-massaging or re-elevating the support for people experiencing trauma recommendation. So yeah, I think a summary of what we talked about today is probably ideal.
Yeah, I think that's a great idea, Kelly. Thank you for that. Anything from our subcommittee members? Okay, moving on to item number 10. We're back to public comment. This is for discussion only. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241021. And Kelly, if you want to share any housekeeping details.
Sure. So Kelly Marshall for the record. Again, if you would like to make public comment and you are joined virtually, please just use the raise your hand button. Or alternately, you can dial 253-205-0468, and when prompted, enter the meeting ID 894893752998. And you can press *6, and I will note that and unmute you. So Chair Shell, I don't have any prompts to unmute anyone, and I don't see any hands raised.
Okay, thank you, Kelly. That will conclude public comment. So before we adjourn, do any of our subcommittee members have anything else to bring up today?
This is Stephanie Cook. I have a quick question. Does the SURG and its subcommittees present to the interim Health and Human Services Committee to the legislature in the interim?
I don't know about interim. I would turn that over to Kelly or Dr. Kearns.
I would actually defer to Dr. Kearns if she's available.
Dr. Kearns, are you still with us?
I am. And yes,
Hello.
hi, thank you. Terry Kearns for the record. Stephanie, to answer your question, the AG and I have presented to the interim HHS committee in the past. So I would imagine it's always been when we have the actual report and recommendations completed, but I don't know if you're suggesting that maybe we should do it before then.
No, I was just gonna say I think that's cool because then they've got that information in the interim as they look towards another session. So yeah, just asking if that was happening here. Cool. Thank you.
Okay, so on that note, we're at adjournment. Again, thank you so much, Dr. Dixon, Chelsea, and Kelly. We thank you all and appreciate all of you. And we will look forward to seeing everyone at the SURG meeting in January and then our subsequent Treatment and Recovery Subcommittee. So thank you all and have a good holiday. We'll see you soon. Thank you.